So my topic is preoperative assessment of the anterior shoulder instability. As you all know, the anterior shoulder instability basically has two essential lesions: the Bankart's and the Hill Sachs. And Bankart's lesion is the avulsion of capsulolabral complex from the anterior inferior portion of glenoid. And Hill Sachs defect is caused by the dislocation when the posterior part of the head is lying against the anterior rim of the glenoid. So it causes a compression fracture there. So to address this, we have different options of doing a arthroscopic Bankart repair, which restores the anatomy by doing a capsulolabral restoration and as well as capsular retensioning. And another procedure is Latarjet, where we are using the bone augmentation procedure. We can also add remplissage to a repair to augment this repair. So in the last 2 decades, arthroscopic Bankart repair has been very popular surgery among arthroscopy surgeons and orthopedic surgeons. And everyone wants to just sort of do this surgery for all instability surgeries. But the results in literature are presenting differently by different authors. Adams, in its meta-analysis, came out by studying 12 studies of arthroscopic Bankart repair. And they found that there's a recurrence rate of 13.7% on an average, ranging from 7 to 20%. And if you consider the athletic shoulders, this recurrence rate even goes up to 20% and more. So this study found that younger age at operation and preoperative glenoid defect, these are the factors which significantly influence the recurrent instability. So why do arthroscopic Bankart repair fail? Pascal Bolo in his study in 2006 identified these risk factors of failure. And he found that if the age of the patient is less than 20 years at the index surgery, the recurrence risk of failure was 31% after Bankart repair. If the level of sports participation is competitive, the risk of failure is 50%, and 33% in contact and overhead sports, and 19% in hyperlax patients. And if you can see Hill Sachs lesion and glenoid bone loss in AP view on X-ray, the risk of failure of arthroscopic Bankart ranges from 30 to 40%. So he used all these risk factors and quantified them by giving points and came out with this instability severity index score and suggested that if the score is more than 6 and you proceed with arthroscopic Bankart repair, there is a 70% chance of failure. This score has been validated by different authors, including Lupini, who came out with similar results, similar to the Pascal Bolo study, and suggested that if the Bankart repair is limited to patients with less than 3 score, there is significantly less risk of recurrence. But some others have challenged this validity of instability in the score, particularly the radiographic domains. They say that just the mere presence of glenoid bone loss and Hill Sachs lesion on an X-ray cannot be taken as significant. If you see them, you have to quantify them using CT or MRI to make a decision of significance of the lesions. So most authors would agree that failure to recognize bony defect is the main cause of failure. So Preventure in his study in 2010 suggested that we can have a fair bit of idea about glenoid bone loss from history and examination. So in history, if there's a high energy mechanism of injury, or if the arm is abducted more than 70 degrees and extended more than 30 degrees at the time of dislocation, if most of the instability is in the mid-range of abduction, if there is progressive ease of instability, and if there is a prolonged history of instability, these all things in history would suggest that this patient may have significant glenoid bone loss. And also in examination, if you see apprehension is positive in the mid-range of abduction with lesser amounts of external rotation, this would also suggest that this patient may have significant glenoid bone loss. And when from your clinical examination and history, you have a suspicion, then you have to evaluate it both on the glenoid and humeral head side. We will do it one by one. While assessing the glenoid, you can do it by X-rays, CT, 3D CT, MRI, and arthroscopy. However, End-face view of the glenoid on a 3D CT is a benchmark which is accepted by most for best quantification of the glenoid bone loss. And while you are quantifying the glenoid bone loss, there are main two issues: how to estimate the original glenoid shape and how to express the defect size. So best shape of the original glenoid can be found out by using the best fit circle of the inferior 2/3 of the glenoid. And also you can use the contralateral shoulder as your reference. And the defect size can be measured by using a area measurement or a linear measurement. Although linear measurement is easier to do because it does not require any special software. So different authors have suggested different methods for quantifying the glenoid bone loss. We'll see a few of these. First is the surface area method, where we just use the end-face view of the glenoid and draw a best fit circle over the inferior 2/3 of the glenoid and digitally calculate the surface area of the glenoid and the osseous fragment to calculate the percentage of bone loss. Another area method is the PICO method, where we take the normal shoulder as a reference and draw a best fit circle and get the surface area of the normal shoulder by using multiplanar reconstruction software. And then you just superimpose this circle on the defected glenoid and calculate the amount of bone loss. Easier method to do is bare spot method, where on a CT only you identify the bare spot and measure the distance from the bare spot to the posterior glenoid rim and the anterior glenoid rim, and take the difference and divide by 2 and get the percentage of the glenoid bone loss. So once you have found the percentage of glenoid bone loss, then next thing to decide is what percentage of glenoid bone loss will be critical for you. Burkhardt and DBR in 2000 identified if there is an inverted pear-shaped glenoid, it's a significant bone loss for the glenoid, and they suggested bony augmentation in these. Low et al. Also in 2004 had a similar finding that if there is a more than 25% glenoid bone loss, it would appear as an inverted pear-shaped. Bolo in 2006 also identified that glenoid bone loss of more than 25% is predictive of 75% of failure after arthroscopic Bankart. So this 20 to 25% of glenoid bone loss has been generally accepted figure by most authors. Now coming on to Hill-Sachs lesion, this is present in 84 to 93% of shoulders with recurrent dislocations, and this lesion is mainly related to end range instability as compared to the glenoid, which causes mid-range instability. So for risk assessment of the Hill-Sachs defect, there are two methods. One is dynamic method, which you do intra-op after you have done the Bankart repair, and you find that by moving your shoulder through end range of motion, you find whether the Hill-Sachs is engaging or non-engaging. Although this would not be ideal since you are putting your repair to a great degree of stress by doing this test. And the other method is glenoid track concept, which you can use preoperatively to find which lesions are significant and which are not. So this glenoid track concept is based on the principle of bipolar bone loss, and it not only gives you an idea about glenohumeral bone loss, but it also helps you in deciding the treatment option for this. So this is basically done by, if you see the figure A, it's a normal glenoid end-face view, and you take the 83% of the glenoid width as the glenoid track. And in the figure C, if the glenoid is deficient, then this track is also reduced because you have to reduce the amount of deficiency from the track. And if you superimpose this track on the humeral head, so this straight line on the GT in figure B is the cuff attachment line, and circular dotted line is the Hill-Sachs defect. If your Hill-Sachs defect is found lying within the glenoid track line, this is an on-track lesion. And if your Hill-Sachs defect, the medial border of the Hill-Sachs defect goes out of the glenoid track line, it's a off-track lesion. So this Yamamoto and Etoy, they did a study based on this track concept, and they used the surgical options based on this concept only, and they found that the recurrence rate was reduced to 4.3% in their study. This was further validated by different authors. Joel Locker in Arthroscopy Journal in 2016 retrospectively analyzed 100 patients of arthroscopic Bankart and found that the recurrence rate was 6% in on-track lesions and 33% in off-track lesions. Another validation of the glenoid track by James Shah in his study of 57 shoulders treated by arthroscopic Bankart, and he found less than 8% recurrence in on-track lesions and 75% recurrence rate in off-track lesions. This study suggested that the positive predictive value of an off-track measurement was 75% compared with 44% for the glenoid bone loss for more than 20%. Once you have done the pre-op assessment and you have decided that you're going to go for an arthroscopic Bankart, you can do the final assessment while doing arthroscopy and assess all the soft tissue quality and glenoid and bony defects on the humeral head side. And even then, sometimes you are in for a surprise that you find that the soft tissue quality is not good for repair and you have to change your mind. So in his review, White et al. In Journal of American Academy of Orthopaedic Surgery in 2019 gave out this algorithm approach for choosing the right procedure for these patients of anterior shoulder instability. So in his view, if the glenoid bone loss is less than 25% with a small Hill Sachs, which is on track, you can safely go ahead with arthroscopic Bankart repair. And if your glenoid bone loss is less than 25% with a large Hill Sachs, which is off track, you can go with arthroscopic Bankart, but you have to add a remplissage procedure to it. And if your glenoid bone loss is more than 25%, or you have poor soft tissues or failed Bankart, you should consider Latarjet in these patients. So to conclude, bony defect is the main cause of failure. Clinical and radiological assessment is the key to recognize the bony defect. The track concept gives you an idea of both humeral and glenoid defects, and the right procedure should be selected according to the patient profile and pre-op assessment. Thank you.